You're watching Best Practice Supervision, a refresher produced by GP Supervision Australia and presented by Dr. Simon Morgan and Dr. Kevin Arlett. We would like to begin by acknowledging the traditional custodians of the land on which this recording was produced and pay our respects to their elders past, present, future and their families.
By way of introduction, my name's Simon Morgan. I'm a GP and I'm a medical educator. I live and work here in Newcastle, and I'm on Awabakal country at the mouth of the Hunter River. And I reside a very long way south of my co-presenter tonight, who possibly needs not a whole lot of introduction because he'll be familiar to you as the chair of the board of GPSA. But Kevin, would you like to introduce yourself?
Yep, thanks, Simon. Yeah, so I'm Kev Arlett. I'm from Townsville in North Queensland. I've been a supervisor for many, many, many years. I've been in my own practice for over 30 years now and have been supervising students and registrars for that whole time. And I think that's enough from me. So I'll pass over to Simon. Away you go.
Thanks so much, Kevin. And as a true lifelong educationalist, I think it's always good to say this is what we're setting out to do. We're going to talk about the core roles and responsibilities of the GP supervisor. We're going to talk about what you guys do in practice. When I've run this for new supervisors in the past, we would talk about some of those conflicts and how to manage those, but really just broadly looking at those. And then through that lens, I guess, starting to think about the principles of best practice supervision. So what constitutes best practice in the way we can supervise our registrars? And I guess that's probably, in some respects, an unashamed excuse to do the third of these objectives. And that's to kind of point out what resources we have to support your job. But we'll make a start. Traditionally, when we think of the role of the supervisor, we think of what the GP supervisor does in practice. It's these two overlapping domains. It's clinical, so-called clinical supervision and so-called educational supervision. And clinical supervision traditionally is this clinical oversight of the registrar's patients. It's maintaining patient safety, quality care, and establishing the registrar is practicing safe medicine. Now, I love this cartoon, and I love it because it actually illustrates the point really well, that once you've got a registrar in your practice, they're often practicing behind a closed door. And without opening that door physically and certainly metaphorically, we are not going to have a clear sense of how safe our registrar is. But the other reason I like that cartoon is it takes me back to when I was a new registrar and I'd arrived in the Northern Territory, and I was sort of embracing the territory lifestyle, and I started not shaving and I couldn't be bothered ironing any shirts, and I was really sort of getting into the lifestyle. And I remember ringing a patient once and I gave her some results over the phone. And at the end of the call, she said something like, "Doctor, just need to ask you something." And I said, "Yes, of course." And she said, "Is everything okay?" And I said, "What do you mean?" She said, "I couldn't help noticing last time I saw you that you looked a bit disheveled and you're unshaven and your shirt was pretty wrinkly and you looked like you'd been sleeping in the car." Sorry, no, everything's fine. I just thought that's what you did when you came to Darwin. And she sort of said, "Well, not always." So when I see that picture, I sometimes think that's perhaps what she saw in me, the fifth doctor. A point well illustrated, I think, by this cartoon, that our role as supervisors is absolutely about patient safety. And how do we do that? And remember, this is an overview covering some broad themes. We're going to talk briefly about ad hoc supervision and ad hoc teaching, but also around this sense of assessing competence and this sense that if somebody from the college or your colleague said, "Can you give me in a snapshot an assessment of your registrar's competence?" the expectation that we must always be able to do that, and how that changes over the period of the placement. So that's clinical supervision. Educational supervision is the other half of that Venn diagram, and that's the registrar learning, guiding the registrar's educational development. And these are sort of core teaching learning themes: identifying learning needs, formal teaching, quarantine teaching time, that sort of opportunistic informal teaching, and obviously assessing and providing feedback. And so these two overlapping circles of clinical supervision is the patient safe, educational supervision is the learner learning. for a long time sort of regarded as that's the way supervision worked. Until a few years ago now, a very excellent paper was published by one of our colleagues, Susan Wern. And Susan was a GP up in the Territory. She worked in Alice Springs, but she has also worked extensively in Canberra with the Department of Health. And she led this paper, which was a review, basically, of what a supervisor is in general practice. And this had not been done. Surprisingly, this work hadn't been done. And there was not a really clear sense of what supervisors in our context did. Lots of stuff on nurse supervision, on psychology supervision, but not in general practice. The resident was conceived, but you can swap that for registrar. But I've highlighted the bit, and this is the definition they came up with, which includes clinical educational, but also personal development. And I'd like to think some of you, as I presented those first two circles, were thinking, well, what about the personal side of things? Is the registrar learning? Are the patients safe? But thirdly, is the registrar okay? And that really important element of supervision of pastoral care. I'm trying to kind of give you a sense of how our roles have been defined over time. And just a couple of academic papers. It's always nice to chuck something in to make it look like I've done some kind of literature review rather than just everything being a little bit homespun. But this paper is actually now very old. Look at that, it's 21 years old. But I don't think the themes have changed. And I'd really like to think when you read what this Dutch researcher found 21 years ago in the Netherlands, general practice settings, is applicable to here in Australia. What are the core characteristics of a good supervisor? And hopefully they're resonating for you. Research I will talk about is actually something much, much, much closer to home. And that was done by the team at GPSA. And they actually published a few years ago now on the attributes of high quality clinical supervision. A little bit more around the setting than the supervisor, but as you'll see, incorporating both. I hope as I present these points, again, they're all going to be kind of, yeah, I really aspire to that. Yeah, it's a challenge to meet that, but we do our best. Yes, they're absolutely the things. So continually refining, improving practice. So that sense of always trying to do better. Optimizing all learning opportunities. So breadth of patient exposure, breadth of exposure to different clinicians in the practice, breadth of clinical settings, nursing homes, after hours care, that role of the pastoral carer again, the input of the whole team, which I think incorporates a little bit of that of all learning opportunities, learner-centered supervision. So really saying, as opposed to I'm the teacher, this is how we do it, you're the learner, how would you like to do it? Some of you, many of you will know James Brown from the RACGP, and he's done a lot of work on professional identity. So that whole, either, I guess, subtly or more overtly, building the registrar's identity. And also, one of the things around reflection and delivery of quality feedback. I'm hoping all those terms, all those attributes and competencies and broad roles are starting to gel, and you're thinking, yeah, that's kind of where I'm at. But let's get to some more specifics. What do you see as the roles of the supervisor? And Kevin, I'm curious to know, how would you answer this question? What do you see as the chair of GPSA? What do you want our supervisors to sort of put forward to see themselves in this capacity?
To become a good role model and to become an available expert for those registrars to come and discuss anything at any time. So I think it's important to make sure that the registrar is supported. And it's not just the supervisor. Our entire practice will support the registrars that come through our practice, right through from other doctors, the nursing staff, the practice manager, the office staff as well. And in fact, you often get a lot of information about your registrar from the office staff, especially the front desk receptionists. So I think you have to be in communication with everyone around the registrar as well as the registrar themselves.
Promoting that general practice career choice is a good choice and to hang in there. It's a pretty tough time for general practice. It's a pretty tough time for general practice training. And I think that sense of inspiring and motivating and encouraging is good. That's all fabulous. And it's really nice because, you're moving very nicely away from that sense of, our core job is to maintain patient safety, yes, and to be educating, yes, to all those other roles. Well, let's unpack some of those and let's do it through the prism of a family, or at least a community that you may be familiar with. The first one, as we talked about, is the teacher. At the end of this, I'll put up the RACGP list of 10 roles, which some of you may have seen. It's in their new Supervisor Professional Development online package. I confess to both having contributed to writing that, but also being a little bit overwhelmed with some of the terminology in those 10 roles. But they talk about not a teacher, but a learning enabler. And I really like that. This is the Simpson teacher. And of course, for many supervisors, that's the thing. I've got to be a teacher. I've got to teach. I've got to have this sort of front of knowledge. How do I do that with? And that's a really challenging role. And we talked about the clinical overseer, that absolute paramount and sort of foundational responsibility of looking after our registrar's patients. Now, I'm sure there's Simpsons fans out there, and you may have thought, why has he chosen Mo as the pastoral carer? I don't know. I kind of see Barman as, somebody who listens to somebody's life story and reflects back and things. Maybe cranky old Mo isn't that person, but our role as pastoral carers. And you'll be pleased to know, if you didn't know, that GPSA take a very strong interest in that, both practically, but also in a research setting. I'm neglectful, and in fact, you're going to pull me up here because I didn't include mentor directly. I should have, and in all the work I do, I often used Homer Simpson as the mentor. And I've used Homer Simpson because he was actually described as a mentor once in a paper I read, which is quite extraordinary. So remiss that he's not in this collection of the usual suspects. Marge here is the role model. And I guess I saw both role modeling and mentoring. And the difference, maybe mentoring is a bit more active. I will mentor this registrar, versus role modeling is actually a bit more passive, and it happens almost invariably. So what you do, the registrars will observe. They may choose to role model differently. They may choose to role model similarly, but I think there's that sort of more active approach in mentorship. And certainly some thornier issues where a supervisor becomes an employer, and how do you reconcile that with somebody who's trying to support a registrar's well-being when maybe there are industrial issues, and certainly around assessment and how do we give a frank and fair assessment of a registrar's performance in the context of them struggling and needing to try to support them in other ways. Kevin.
Can I just jump in there? The role of assessor is going to become much more important now that the colleges have taken over training. Some of that has been happening a little bit with GP supervisors, but there will be some more formal assessment that will come into the new programs. So just be aware of that. It's not terribly onerous, but it is different. And you'll find that you will be assessing as compared to a fellowed GP. So some of the early registrars may well get some fairly poor assessments, and you have to be prepared to talk to them about that and as to why that might be. And it's because they're early in their career and they're aiming to improve on that. So if you just give them very good assessments, that won't be terribly useful. So just be aware that assessing will become a much bigger role in the future.
No, thanks, Kevin. And you make a really important point. And I think as an ex-GP Synergy medical educator, it was assessment according to the registrar stage of training. It's a very different concept now to say, is this registrar at the stage of a fellow when they're 3 weeks into term? And so that needs to be couched appropriately. So lots of roles. And as I promised, that's the RACGP list. There is no really equivalent schematic representation of the roles as ACRM see it, according to their supervisor handbook. And you can see some of those terms are a little bit impenetrable and obviously may overlap. But the point being is it's a complex job, and some of those things actually potentially conflict with each other. The need for ongoing PD and the need to be upskilling is paramount. So we've talked about those three circles: personal, educational, clinical oversight. And then we talked about all these sort of roles. But that's all nice, conceptual, and kind of, occupy that space. But what does best practice supervision actually look like? And I guess that means, what are the tasks? How do I implement this to make my role as effective as possible for my registrar through the new supervisor guide, which I'm hoping some of you who've been around for 20 years are not thinking, oh, that's beneath me, because hopefully, you would actually find some interesting material in this. We came up with this list of what constitutes best practice. And this is it. And this list could have been quite different, and we could have sliced and diced these things in a number of ways. But GPSA have come up with this kind of concept around what is best practice through the sort of more practical tasks. The first one is establishing and maintaining a high quality learning environment. What does that actually mean? And probably of all these, that remains the most conceptual to this point. What GPSA have done to date and are building on currently is this thing called the GPCLE. It stands for the General Practice Clinical Learning Environment. And through a research process, we came up with 6 core elements of a practice that is a really kind of rich learning environment. And I'm not going to go through them, but you can see there's 6 elements and a number of objectives beneath that. We recognize this is a nice framework, but it's not yet really a directly applicable tool for to use. I think if you are keen to really think about, is my learning environment, is my practice offering all the opportunities and providing that kind of positive environment for my registrar as possible, then I would absolutely encourage you to read this framework. We are keen to develop tools around it, so you'll see those coming, but it's really very much around the environment being right. And again, Kevin, are there any sort of good tips around how do you actually just nurture the registrar walks into this environment? How do you make it feel like, yeah, this is the place for me to learn, to be safe, to get my head around this thing called general practice?
The first step to a safe environment is psychological safety of both, and I think that's really important. There's a comment about regular practice clinical meetings, and that's a good way of creating that collegial atmosphere as well. Regular conversations, encouraging questioning, regular feedback, ring-fenced education. You must ring-fence it, and that education and discussion time needs to be not interrupted. So when you're having training sessions, tell your staff you don't want to be interrupted over that time.
Thanks, Kevin. Clearly, there's a hierarchy between the supervisor and the registrar. You're an employer, you're a supervisor, you've got ultimate responsibility. One of the things for me is aiming for a relatively non-hierarchical structure, as in recognizing or encouraging the registrar to think as a GP, to see themselves as a GP. Yes, they're a registrar, they're training, but they're also, on the other hand, a GP as you are, and having conversations that are more peer discussions than hierarchical, which clearly they're going to default to. And that also becomes two-way dialogue around feedback and obviously being able to comfortably expose your gaps in knowledge and exposing your own mistakes and all that kind of thing that makes them feel like, oh, this is a good place to be because I don't feel like I'm the only one who doesn't get it.
I think that's a good thing. What I do with my registrars is I explain to them that I actually consult with my other colleagues as well. So if you get a tricky rash, it's not so hard to get someone to come and give you a second opinion on the spot. That's very useful. In fact, I got caught with a funny rash a few months ago and I asked my colleague to come and have a look. It was all these black spots all over someone's back. And she noticed that this girl was actually wearing a dark coloured T-shirt and she grabbed an alcohol wipe and wiped them all off for me. So that put me in my place. And there was a bit about co-learning as well. And I think that's really important, that you can learn as much from the registrars as they can learn from you. And I think that's really important as well, because obviously as we get a bit older, some of the stuff that we learned when we were students and registrars is now well out of date. And you do need to keep up, and medicine is a constant learning environment.
I think possibly the first of these 6 tasks for the supervisor is a bit of a cop-out because it's a bit broad and it actually incorporates many of the others. So let's move on to some that are a bit more tangible. And I guess the second one, and it's nice to think that this aligns relatively well with the content from both ACRM and the RACGP in the way they think about the tasks of the supervisor, is really good preparation for the registrar's commencement. And again, another resource that I would point to, if you're not aware of, is the GPSA Before the Registrar Starts document. If you're not aware of this, please have a look. It's a really, really useful guiding resource. There's a lot of content in there that is much more relevant to your practice manager, administrative stuff that's critically important, but something that you probably don't need to think about so much as a supervisor from that education, clinical perspective, but clearly covers things like adequate orientation to the practice and time to play with the software and referral sources and all that sort of thing. So best practice supervision is absolutely preparation for the registrar before they start. Now, you might think, well, why is Simon telling me this? Because clearly that's apparent. We're saying this because it sometimes doesn't happen, or it doesn't happen often enough that it's just really worth reinforcing. So for those of you who are doing it well, fabulous, and those who maybe it's less rigorous, yeah, this is a really useful document. The third one is facilitating teaching and learning. This, for many supervisors, becomes the kind of most apparent element of their role. The patient safety stuff happens in the background, but I'm a teacher. I have to educate my registrar, support their learning. And we are not elaborating on this in any depth, although I'll cover a couple of things. And these, over time, is the distillation of tips around teaching and learning. So the first one is having a bit of a vocabulary. And I do a lot of teaching on clinical reasoning. I think it's such a wonderfully rich area. And this isn't to impress your registrar with words like dual process thinking and premature closure and cognitive bias, but just to genuinely know some of the terminology that's going to help your education. Identifying registrar needs, as an educator of many, many years, think this is something that on the whole doesn't happen as well as it might. This is absolutely a registrar's responsibility to say, where are my gaps? But it is the role of the supervisor to help facilitate that. And we're thinking here about the unknown unknowns. Where should we focus our energies? For me, registrars divert us as supervisors to say, what's the diagnosis? What's the treatment? What's the dose of the medication? All of which generally is stuff that can be looked up. What I think we should take a focus on as supervisors is skill development, consultation skills and counselling skills and clinical reasoning skills. And yeah, sure, feed into the diagnosis and the management, but often registrars drive this by seeking knowledge. Supervisors facilitate that by providing knowledge because it's easy enough to do. And in fact, one of the RACGP roles is information providing. Yes, that's an important thing of what we do. But if we can have that focus on, I actually want my registrar to learn these skills more than take away this knowledge, I think it'll hold us in good stead. And similarly, yes, it's all about the clinical, but let's think about population health and let's think about professionalism and let's think about organizational skills and those other aspects of practice, which again, they're going to be less able to learn at a workshop or from the textbooks, and focus on the consultation, this thing that we do hundreds of thousands of in our careers. How can they really, really, really develop this skill so that, you know, when they see a patient, they can just do it. And sure, it doesn't matter if there's all this uncertainty and they've never seen the problem before, they've got a process that sometimes gets missed. I'm really encouraged. I think the new training landscape, certainly with the RACGP, is going to have much more a focus on the consultation as this vehicle. One of the points from the GPSA research around utilising the whole supervision team, I think practice nurse, practice manager. So these are just tips. You're probably going, yeah, I know these, that's good, but nice maybe to have them reinforced. This whole ask before tell. Hey, Kev, I've seen this person with a rash, all these weird black spots, never seen it before, don't know what to do. What do you think it is? And you go, yeah, I've seen this before. It's probably just off her t-shirt. Kevin says, as an experienced supervisor, well, what do you think it is? I've got a couple of ideas, but you tell me first. And I know that sounds so basic, but sitting in frequently in the practice and observing this, it commonly doesn't happen. And obviously mixing up the teaching method. What can we offer you by way of support? the GPSA teaching plan. So these have been around now for a number of years. We've now got over 100 of them. We've got content in Aboriginal and Torres Strait Islander health. We've got consultation skills, about 16 of those, absolutely focusing on that, but lots and lots and lots of clinical ones. And I've been told that registrars are downloading these for study, independent study, supervisors are using them, hopefully.
And they are very, very useful, especially if you're running out of ideas as to what to work with your registrar about. But obviously you do need to talk to your registrar about what their needs are and then pick the correct ones that you can work with.
There are lots of clinical content and our more kind of educational development are contained in the guides. And again, hopefully you've seen these. In terms of teaching and learning, there's one on practice-based teaching and there's one on planning learning, written for supervisors by GP supervisors and educators, and really, really accessible. And in fact, get the registrar to read them as well. I'm all about empowering registrars to advocate for things going well. So, yeah, I'll be doing a bunch of teaching with you. Read this guide and you'll know where I take my focus. You'll know a bunch of teaching methods we can employ. Read this guide and then we can talk about your learning gaps and we can, both of us, unpack them a little bit more effectively than if I was just to have this knowledge. So those guides are good. We've got some resources as well. And this is one called the 4R self-assessment tool for GP registrars, which is really around learning needs and talks about the way you as a GP, the way a registrar as a GP registrar works and the way they face 4 directions. They sort of have to interact with the patient and that's all about the relationship. They have to interact with the problem and that's all about reasoning what's happening. They have to interact with the system, the wide world, and that's the responsibility to the outside world. And they have to interact with themselves. They have to reflect. Happily, they all are R words, and we've turned that into a bit of a resource that you might like to use with your registrars to help identify what their gaps are. We're getting through this list. We're up to number 4, and none of these are hopefully unfamiliar to you. Nice, rigorous, positive, supportive learning environment. Registrar prepared to come, so we know what they're expecting. Teaching and learning, and obviously the other really big part of that is assessment and giving feedback. The way we can give feedback has evolved over time. But that's Ned Flanders. I think Ned Flanders does give feedback. He does sort of provide his assessment of things through his particular prism, and he gives feedback as he goes. So I hope that's a good representation of feedback. And a few tips. And the first one is just have this list in front of you or a list like this in front of you and make sure when you give feedback that you adhere to it. I heard 2 days ago of a colleague who had feedback delivered to them about their performance, which one could argue was couched as a positive to say we need to support you, but was actually quite critical in front of other staff members, unannounced and sort of very vague and not really specific to what's been observed. We all know feedback remains something that can be given poorly. So implement your best feedback practice strategies, make it regular and frequent. And I think the other thing to say, and I really encourage supervisors to say at the outset is, hey, welcome to the practice. You will find I will give you a lot of feedback. This is the way it works here. 2 things. One is you may not recognize it as feedback, but I'll be giving you feedback every day, all day, every day. Yeah, sure, we'll have some formal feedback sessions and it'll look like feedback and smell like feedback and it will be feedback. But there's a whole bunch of other times I'll be giving you feedback that you may not recognize it, but I'm not going to say this is feedback. I just want you to be aware that I'm giving you a review of your performance as we go, firstly. And secondly, can you please do that back to me? I want that. I encourage that. It will really help my job as a supervisor, not just educationally, but if you made an observation about my clinical practice, please, it will help you receive feedback better if you're comfortable giving me some feedback. So they're my 2 things. There's the literature, and we'll talk about the receipt of feedback, how we can actually encourage our registrars to better receive feedback. But the first principle in any feedback model we use is to ask the registrar how they thought they did first and this culture. And that's very much part of the whole GPCLE and a robust learning environment. Kev.
It's very difficult for the registrars to give us feedback. I know you've said that you encourage people to do that back to us. Is there any tips around that?
Firstly, I accept that that is the case. Registrars will feel like they don't know what they're doing and that there's a power differential and they'll feel quite uncomfortable. So that's fine. I do think, though, aspiring towards a less hierarchical structure and that whole notion of we're both GPs, we're both bumbling our way through this together. Sure, I've been around the block a few more times and I'm going to give you a lot of guidance, but I don't know it all either. Can be helpful to kind of diffuse that to a degree. I think being overt and saying, I want this, I encourage this. If you see something clinically that you think I could have done differently, I'd really encourage that. It's the only way I can learn. If you think I do something educationally that could do a different way, not wrong or badly, but in a different way, I'd encourage that.
Yeah.
That doesn't get away from, oh, I can't tell the boss that. Fine, but it may help.
Yeah.
I don't know. Do you have any tips on that?
The great tip, she said that she lets the registrars go through her consults as random case analysis. And that's a great way of doing that. We're obviously all human as well, and it doesn't hurt to have registrars sit in with you. And I've had a number of times where registrars or students have sat in with me and commented on my communication style that I didn't realise, or my knowledge may have been slightly out of date. So there's a whole range of things like that. So having them sitting in with you as well as you sitting in with them, especially early on in their career, I think is a good thing.
That's, I think, a wonderful suggestion too. And there's a guide on feedback too. We're nearing the end of this list of tasks, and possibly you could argue this should be number one, but this is wellbeing and safety. So I like the term safety for patients, but I also like the term safety for registrars. But if we think about this clinical oversight role and how to actually implement that, so what is best practice in clinical oversight? There's some useful tools and useful approaches. Again, many of you may be using, but a reminder for those of you who are not. So there's the call for help list. This was done by Jared Ingham a few years ago now. Jared's a very experienced medical educator from rural Victoria, who really put together something that possibly was 20 years overdue, but nobody thought to do it. And this is a really nice list of clinical areas that a registrar is likely to struggle with, maybe not has seen or maybe unfamiliar with. And essentially, he'd never really envisaged this to be a checklist. GPSA have turned this into something of a checklist, but I don't really mind how you choose to use it, as long as some way the registrar eyeballs this, you eyeball this, and there's some kind of mechanism of saying, I've really not seen any antenatal patients, or gosh, my pediatric exposure was a bit sketchy. Yes, I got through on the criteria, but sick kids in the community worries me. And so having a sense of, will you call me for these ones, or we'll look at the notes afterwards. Some process to say, this is how I call for help. The other really nice thing, so what I've put up here is the GPSA sort of version of the call for help list, but if you Google call for help list RACGP, you'll get the original research paper, which has got the list. The other really nice thing in this is, as you can see, the uncertainty flags. And these are broader situations than antenatal care or workers' compensation, but areas where a registrar may elicit a lot of uncertainty. And as we know, uncertainty can really derail registrars. And it may just give them permission to say, I need to call you for these things. So it's a really useful tool. There is also colleges now will take on that responsibility of the so-called early safety assessments, clinical knowledge tests, early random case analysis or direct observation activities, so that either mandated external assessment to say, yeah, I'm happy my registrar is safe, or something that you may well implement yourself. And we do this in an iterative way all the time, clearly, when we're talking to registrars about what they're seeing. But I would put, again, to you that notion that if you suddenly somebody said to you, is your registrar safe? You really need to be able to answer that in an ongoing way. And that's, again, maybe sounds really obvious, but I think that will help us drive that sense of safety assessment. The RACGP, at least, in their professional training, are talking about implementing this so-called Safe Start process, which is basically for new registrars, or indeed those new to the practice and you're unfamiliar with their competence, a very rigorous process of checking what they're doing, reviewing every patient, if not in person, then by notes review at the end of the day. That is not mandatory, but there is talk about that becoming a bit more standardized. So you may see that coming. And many of you who are RACGP supervisors will have seen the onboarding program for the new professional training through the RACGP, and that's where this is talked about. Around training and what the requirements are, in terms of your supervisor PD requirements, certainly through the RACGP, they will be met this year just by virtue of upskilling and getting across everything that's required for training for 2023, and then they will roll out in 2024. In terms of your CPD requirements, being a supervisor, certainly a primary supervisor, will account for a significant number of your 50 hours of annual CPD.
It's 30 hours out of your 50, so it's a significant amount towards that. So that's good.
Another resource that I would point you to if you're not already using or a version of is the so-called clinical supervision plan. And this is a really nice document that I was introduced to as a GP Synergy medical educator. The RACGP on the right, that document, have developed their own clinical supervision plan. And this is just a very clear plan about when the registrar will call for help, who they should call for help, how they should call for help, that you can go through with them at the outset and very clearly establish the sort of parameters around calling for help. ACRM do not have an equivalent plan, but have certainly casually expressed that the version that we have developed, the GPSA supervision plan, is something they're happy for their members, their supervisors to use. But if you're not using one of these tools, certainly the RACGP, I think, will be mandating it, and ACRM will be encouraging it, at least, to use a tool like this. You will find it hugely helpful, such that you'll be just heading off those early problems. And when a registrar wants to call you, doesn't know quite how to do it, quite when to call, quite know who to call. When we think about patient safety, it's not just what we're talking about, reviewing performance, assessing the registrar's competence, giving feedback, but it also, in this nice circular way, it's about identifying a registrar's learning needs and, of course, their clinical gaps, and, of course, that would potentially be areas that they may be less clinically sound on, and how that impacts on practice-based teaching. And so I kind of like that model of thinking that patient safety links not just to sitting in and watching a registrar work and going, yeah, they're safe, but thinking, well, where are the gaps? Let's identify them. What do I pick up during practice-based teaching, or where do I focus my energies? And obviously reviewing their performance and then giving appropriate feedback. And I guess I also like this term of registrar safety. I could replace the word safety with well-being, but it is safety in many respects, particularly the registrar who's relocating, who's dislocated from family, who's terribly anxious and overwhelmed by the newness of general practice. It's safety. And so again, really just identifying, flagging this, but an early well-being/safety assessment. This is for not about patient safety, but registrar safety. How are you getting on? How will you get on? Do you envisage any problems? Are you somebody who's going to struggle with the anxiety? Let's put in place some structures to support you. And as the RACGP roles talk about, there's the sort of advisor and advocate role. And obviously, I put conflict resolution because that's something that GPSA have taken a bit of an interest in over the last 12 months as well. And lastly, undertake ongoing professional development. That's what this is. Just to point out, and this is really to say, we have a very good guide on teaching IMGs, which is a particular learner who have identified issues in a number of areas, obviously variably, and this guide to help support that type of registrar. And also the registrar in difficulty. So, not the undifferentiated registrar who bowls up, but there's somebody who, they've got a problem, clinical issues or a learning problem or personal problems or a range of other things. How do I identify those? And the only reason I put all those dot points in is for any new supervisors or relatively new who are thinking, gosh, there's lots to learn and it's all pretty tricky. There's this really nice model of the parallel between clinical practice, what we do with patients, and educational practice, what we do with registrars. And you can see that could be how we manage patients. but this is actually how we manage registrars. We do all these things. We look for risk factors, think about what the causes are. We try to prevent it happening. We try to have early identification. We may need to investigate the problem. We make an educational diagnosis. We manage them, and we need to follow up on safety net. The 2 guides for each college.
Yeah, I was just going to give a little hint for registrars in difficulty. Always beware of the registrar who doesn't ask you questions. That's something that I've discovered over the years. If I have a registrar who doesn't come to me with questions, just be very careful of them.
Kevin, thank you so much for your contributions. It's wonderful to work with somebody who's so experienced and obviously has the standing in the organisation as yourself. So thank you.
My pleasure. Don't forget, just take advantage of those GPSA resources that Simon has explained about, and there is many, many more on the websites as well. So just go across and explore, and hopefully you'll get some useful information for your registrars and your supervising. Thanks.
Bye-bye.
Thanks for watching. We'd love your feedback. Please comment or subscribe to our YouTube channel for updates on new videos. If you'd like to ask a question or suggest a topic, you can contact us via our website at gpsa.org.au. GP Supervision Australia is supported by funding from the Australian Government under the Australian General Practice Training Program.